Welcome to another deep dive, meticulously crafted for you, our dedicated medical professionals. Today, we're unraveling a condition that frequently presents as, well, a genuine diagnostic conundrum, Pronator Teres syndrome, or PTS. It's a particularly deceptive challenge because its symptoms so often mirror those of a far more common issue, carpal tunnel syndrome. And that, unfortunately, can lead to misdiagnoses and, frankly, prolonged patient discomfort. Our mission today is to pull back the layers on PTS. We'll explore its often subtle underlying causes, equip you with the precise tools to accurately identify it, and delve into the very latest evidence-based approaches to effective treatment. Joining us to shed invaluable light on this intricate area is the renowned Professor Mo Imam.
Thank you for inviting me. This is indeed a truly vital topic for clinicians across various specialties. A precise understanding of PTS isn't just academic. It can dramatically improve patient outcomes and crucially help us avoid unnecessary or ineffective interventions. So yes, I'm keen to delve into the anatomical nuances and the, robust clinical evidence that truly guides our contemporary practice.
Precisely. Our objective for this deep dive is to furnish you with the insights needed to confidently diagnose and manage PTS, making sure you're comprehensively well-informed on this often overlooked median nerve compression. So let's unpack this fascinating clinical challenge. Professor, let's begin with the absolute fundamentals. For those perhaps less familiar with its subtleties, what exactly is Pronator Teres syndrome and how does it clinically manifest in our patients?
All right. Pronator Teres syndrome, at its core, is a compressive neuropathy of the median nerve. Simple enough, perhaps. But what's critical here, and often the source of diagnostic confusion, is that this compression occurs at the elbow level.
Okay, the elbow.
Yes, or more specifically, within the proximal forearm. Patients typically present with a rather persistent, aching pain, which they localize to the proximal volar forearm. This pain can, quite frustratingly for the patient, radiate distally down into the hand. Along with this discomfort, they very commonly describe sensations of tingling, numbness, or perhaps a burning quality paresthesia. This usually affects the thumb, the index finger, the middle finger, and importantly, the radial half of the ring finger. So that classic median nerve distribution.
Right, the typical median nerve pattern.
Exactly. Now, a key clinical pearl here, which we'll definitely delve into further, is that this sensory disturbance can uniquely extend to the palm itself.
Ah, the palm. That's interesting.
Yes, it's a key differentiator. Now, the symptoms aren't static. They are invariably exacerbated by specific activities. Think of any movement that involves repetitive pronation and supination of the forearm.
Like tightening screws, perhaps? Or turning a doorknob?
Spot on. Or activities requiring forceful gripping. Patients often report easy forearm fatigue and significant discomfort during actions like squeezing or sustained turning movements. In more severe presentations, it's not uncommon for patients to describe sharp, shooting pains. These travel rapidly from the elbow down to the wrist and into the hand, sometimes even waking them from sleep. Although, mind you, the nocturnal waking pattern is generally less consistent than in, say, carpal tunnel syndrome.
That's a useful distinction. It paints a very clear picture of the patient's experience. Now, what about its prevalence and the typical demographic we tend to see affected? Is this a condition that should regularly be on our differential diagnosis list?
That's a crucial question for clinical practice, isn't it? Compared to other neuropathies, particularly its more famous cousin, carpal tunnel syndrome, Pronator Teres syndrome is relatively rare.
Okay, how rare?
Well, its reported incidence is less than 1 per 100,000 annually, so fairly low. It accounts for less than 10% of all median nerve entrapments.
So important to know about, but maybe not an everyday diagnosis for most?
Precisely. You won't encounter it as frequently as CTS. Clinically, we tend to observe it more often in females, particularly as they approach their 5th decade of life, so typically between 40 and 50 years old. There's also a demonstrably increased risk in individuals with, well-developed forearm musculature.
Such as weightlifters.
Yes, or in those whose occupations or sporting activities demand repetitive and strenuous forearm and wrist movements. Think of tennis players, carpenters, maybe individuals involved in assembly line work, that sort of thing. Interestingly, there's also an observed increased risk in patients with systemic conditions like diabetes or hypothyroidism.
Ah, okay, so potential systemic factors too.
Yes, suggesting perhaps a broader systemic predisposition to nerve entrapments in some individuals.
Right. So at its heart, it's a mechanical compression. To truly understand this, Professor, could you walk us through the intricate journey of the median nerve and precisely where these compression points most commonly occur around the elbow and proximal forearm? Understanding these anatomical choke points seems vital for diagnosis.
Absolutely. A detailed anatomical mental map is truly crucial here. The median nerve, as you know, embarks on its journey from the C6-T1 nerve roots, forming part of the brachial plexus. It then courses down the arm, initially positioned laterally to the brachial artery. As it enters the forearm through the cubital fossa, that's that triangular space at the front of your elbow, it must navigate between several distinct structures. This is where things can get tight.
The potential pinch points.
Exactly. The most common site of compression, the one that lends its name to the syndrome, is between the humeral and ulnar heads of the pronator teres muscle itself. But, and this is important, this is just one of several potential culprits. We must also consider 4 other significant anatomical structures that can entrap the nerve. First, there's the supracondylar process. It's a small residual bony projection found in about 1% of the population, extending from the anteromedial aspect of the distal humerus.
A congenital variation, then.
Yes, and often associated with this is the ligament of Struthers, a fibrous band that extends from this process down to the medial epicondyle. If either of these structures is present, they can form quite a tight arch over the median nerve.
I see.
Then, another common compression point is the bicipital aponeurosis, more commonly known as the lacertus fibrosus. This is a thickened fascial extension originating from the distal biceps tendon, spanning across the antecubital fossa and inserting onto the ulna.
And if that's thickened?
Exactly. When this aponeurosis is thickened, which has been observed in up to 70% of upper limbs in some anatomical studies, it can significantly narrow the space available for the median nerve. Passive pronation of the forearm, coupled with contraction of the biceps, can further drag on this structure, leading to direct nerve compression. We've even seen acute median nerve compression in the antecubital fossa following elbow injuries.
Really? How so?
Particularly where a partial rupture of the biceps brachymyotendinous junction created increased tension across the nerve due to a tethered lacertus fibrosis. Surgical decompression in those specific cases led to complete symptom relief.
Fascinating.
It's also intriguing to consider that bilateral lacertus fibrosis entrapment is anatomically possible, even if a patient presents with symptoms only on one side.
Right, so always consider the contralateral side, too.
Good practice, yes. Finally, the aponeurotic arch of the flexor digitorum superficialis, or FDS, can also entrap the nerve. This is the largest extrinsic flexor of the forearm, responsible for flexing your fingers at the proximal interphalangeal joints. Its humeral nar and radial heads can form a tendinous or fibrous aponeurotic arch under which the median nerve must pass. Anatomical variations of the FDS muscle and its tendons have been described.
Such as?
Instances where an anomalous muscle belly or an accessory muscle crosses the median nerve anteriorly, causing intermittent symptoms directly related to that compression. So the FDS can certainly play a role in pronator syndrome at the elbow, and its morphology is worth considering.
So quite a few potential sites just there.
And that's not all. Beyond these more common sites, rarer compression points exist. These include the accessory head of the flexor pollicis longus, often referred to as Ganser's muscle. While it's actually quite common, present in 20% to 75% of people, it rarely causes compression.
Why is that?
Primarily because its typical fibrous, rather than fleshy composition or its usual orientation, means it's less likely to actively constrict the nerve compared to other sites, unless, of course, it develops significant hypertrophy or fibrotic changes, perhaps after an injury. Other infrequent culprits can be things like exostoses of the radius, the ulnar segment of the flexor carpi ulnaris, or even aberrant bands within the brachialis muscle and its surrounding fascial bands.
It sounds like a real anatomical obstacle course for the nerve.
It truly is a complex region, and recognizing these variations is vital, as they can certainly predispose individuals to this challenging condition. The key insight here for you as clinicians isn't just memorizing these points, but recognizing that a comprehensive diagnostic and, if needed, surgical approach must meticulously account for all potential choke points. Overlooking even one can lead to persistent symptoms.
That detailed look at the median nerve's journey, especially those less common compression points, truly underscores why diagnosing PTS requires such meticulous attention. It's not just about knowing the anatomy, but knowing how to test it and how it behaves. So this leads us directly into the heart of the diagnostic challenge. Pronator Teres syndrome is so frequently misdiagnosed as carpal tunnel syndrome. What are the pivotal clinical findings that allow us to confidently differentiate between these two conditions, particularly when we're trying to distinguish it from the ubiquitous carpal tunnel syndrome?
This is indeed where the clinician's diagnostic acumen is truly put to the test. The misdiagnosis of PTS as CTS is, as you say, remarkably common. We're talking 32% to potentially 49% of cases that high.
Yes. And this can unfortunately lead to unsuccessful carpal tunnel decompression procedures, leaving the patient with unresolved symptoms and, understandably, continued frustration. The fundamental difference, as we've noted, lies in the compression location. PTS is proximal forearm, CTS is at the wrist within the carpal tunnel.
Okay, so location is key. How does that translate into symptoms?
Let's break down the critical differentiating clinical features that guide our diagnostic process. First, pain location. In PTS, the aching pain is characteristically in the proximal volar forearm, often radiating distally. In contrast, in CTS, the pain typically originates at the wrist and often radiates proximally, sometimes up to the forearm or even the shoulder.
Right, opposite direction of radiation often.
Often, yes. Secondly, and this is a crucial distinction, nocturnal symptoms. A hallmark of isolated PTS is the lack of prominent night symptoms. If a patient presenting with suspected PTS reports significant nocturnal paresthesia, waking up with numb, tingling hands, it should immediately raise a strong suspicion of coexisting CTS.
That's a very strong flag then. Absolutely. Patients with CTS very commonly report symptoms worsening at night, frequently waking them. It's perhaps one of the most reliable differentiating factors in practice. Thirdly, scenar eminence numbness. This is another highly specific indicator for PTS. Patients with PTS often report numbness specifically in the thenar eminence, that fleshy part at the base of your thumb.
And why is that specific to PTS?
Because the palmar cutaneous branch of the median nerve, which supplies sensation to this area, originates proximal to the wrist crease. Therefore, it completely bypasses the carpal tunnel. Consequently, it remains unaffected in isolated CPS. Its involvement makes it a very strong pointer towards a more proximal compression, namely PTS.
Got it. So sensation over the thenar eminence is a critical checkpoint.
Precisely. And finally, exacerbating activities. The activities that worsen symptoms also tend to differ. PTS symptoms are reliably aggravated by repetitive forearm pronation, supination, and forceful gripping actions, things we discussed earlier. Furthermore, while general forearm muscle fatigue is more common in PTS, visible VR muscle atrophy, that wasting of the muscles at the base of the thumb, is a more frequent and concerning indicator of chronic, often severe CTS.
Those are incredibly valuable clinical pearls. Beyond the patient's objective narrative, what specific physical examination tests do we rely on to help us confirm or rule out PTS versus CTS, and what's their clinical reliability?
Physical examination truly remains the gold standard for diagnosis in these conditions. For PTS, the pronator compression test is paramount.
How is that performed?
You apply sustained direct pressure for about 30 seconds over the Pronator Teres muscle, right along the median nerve's anatomical trajectory. That's typically about 3-4 finger breadths distal to the medial epicondyle. Reproduction of the patient's tingling and numbness in the radial 3.5 digits, the median nerve distribution confirms a positive result. Crucially, this test is generally negative in cases of isolated CTS. In fact, it's consistently reported as one of the most common positive findings in surgically treated PTS patients.
So, a key test for PTS specifically.
Definitely. In addition to static compression, we also employ provocative forearm movements as dynamic tests to try and pinpoint specific compression sites. For instance, to test for compression at the Pronator Teres muscle itself. You resist forearm pronation with the patient's elbow flexed slightly, between 0 to 45 degrees. An increase in the patient's pain or paresthesia during this resisted movement strongly suggests compression by the Pronator Teres.
Okay, and for the other sites?
For potential compression by the lacertus fibrosus, you resist elbow flexion, typically from 100 to 135 degrees, while maintaining maximal forearm supination. The reproduction of paresthesias during this maneuver points toward involvement of the lacertus fibrosus. And for potential compression at the FDS aponeurotic arch, you resist middle finger proximal interphalangeal joint flexion. Now, while a positive result here can suggest FPS compression, it's generally considered less reliable than the other tests.
Why is that?
Because FDS contraction can also indirectly draw the lumbrical muscles into the carpal tunnel, which might then compress the median nerve more distally. So it makes it challenging to definitively pinpoint the exact location of compression with this specific test alone. It's less specific.
Understood. And for CTS, the classic tests?
For CTS, the classic tests are, of course, well known to our listeners. The Tynal sign. This involves light percussion directly over the median nerve at the wrist, in the carpal tunnel area. It causes a tingling sensation or paresthesia to radiate distally into the digits. While, as I mentioned, a tinal sign can sometimes be elicited in the proximal forearm in PTS, its presence specifically at the wrist is characteristic of CTS.
Right.
Then there's the Phelan test, asking the patient to maintain complete wrist flexion for 1 minute. This further compresses the median nerve within the carpal tunnel, hopefully eliciting their characteristic paresthesia. And the carpal tunnel compression test, sometimes called the Darkin test, applying direct, sustained pressure to the carpal region with both thumbs for 30 seconds. A rapid manifestation of symptoms tingling and numbness in the median nerve distribution is a positive sign. And importantly, these CTS-specific tests are often negative in cases of isolated PTS.
That's an exhaustive clinical toolkit. Now, how do neurophysiological studies like EMG and NCS and perhaps imaging modalities factor into this intricate differential diagnosis? Are they the definitive answer?
They are certainly valuable tools, but perhaps not always definitive, especially for PTS, and they come with nuances for each condition. Neurophysiological methods like electromyography, EMG, and nerve conduction studies, NCS, provide objective data, which is helpful. In cases of PTS, however, these studies are often, somewhat surprisingly, negative or inconclusive.
Really? Even with clear symptoms?
Yes, if they are positive, they typically show decreased conduction velocities from the elbow to the wrist, indicating a more proximal slowing rather than across the wrist itself. In stark contrast, CTS consistently demonstrates decreased nerve conduction velocity, specifically at the mid-palm and across the carpal tunnel. And EMG can objectively confirm the diagnosis in a substantial 80% to 90% of CTS cases.
So much more sensitive for CTS than for PTS.
Exactly. So while highly sensitive for CTS, their utility in definitively diagnosing PTS can be more limited. They often serve more to rule out CTS or perhaps quantify any nerve damage present. High-resolution ultrasonography, USG, is also increasingly valuable, particularly for CTS. It allows us to actually visualize median nerve thickening or edema at the entrance to the carpal tunnel and, conversely, a flattening of the nerve within the tunnel.
Can ultrasound help with PTS?
For PTS, however, USG is less routinely recommended. There's more limited evidence supporting its widespread use as a primary diagnostic tool currently. While it can sometimes visualize the compression site, say between the Pronator Teres heads, or identify structural anomalies like an enlarged lacertus fibrosis, the absence of a visible mass or hematoma can make identifying subtle fibrous bands or scar tissue quite challenging via ultrasound. They might simply be too small to reliably visualize.
So useful in specific cases perhaps, but not a routine first step for PTS.
Generally, yes. It's not quite the primary diagnostic workhorse for PTS in the same way it is becoming for CTS. It's also critical to briefly consider anterior interosseous nerve, AIN syndrome, in our differential diagnosis as it branches off the median nerve proximally.
Ah, yes, the AIN. How does that differ?
The key differentiator here is that AIN is a purely motor nerve. Therefore, patients with isolated AIN syndrome typically present only with muscle weakness and fatigue. This affects muscles like the flexor pollicis longus, the pronator quadratus, and the flexor digitorum profundus to the index and middle fingers, leading to that characteristic inability to make a full OK sign. They get a pinch posture instead.
Right, the classic AIN sign.
Exactly. Crucially, they lack any sensory symptoms, unless it's coexisting with PTS or CTS, which can happen. This motor-only presentation helps us differentiate it clearly from PTS, which is predominantly sensory, although it can have subtle motor deficits sometimes. And interestingly, while EMG studies are often negative in PTS, they can robustly confirm AIN syndrome in 80% to 90% of patients. So meticulous manual motor testing of pure median nerve and AIN innervated muscles can really improve diagnostic accuracy here.
That brings us neatly to management. Once a definitive diagnosis of PTS is established, what are the initial, most appropriate steps? Do we invariably jump to surgery, or is there a robust conservative pathway that should always be exhausted first?
Oh, absolutely, the latter. A crucial point for any peripheral nerve entrapment is that the primary management approach for PTS is overwhelmingly conservative, and I must emphasize it is highly effective in many cases.
How effective?
We see improvement in a wide range, reported from 29% up to as high as 80% of cases, without any need for surgery. Initial treatment typically involves a commitment to a 3 to 6 month period of dedicated conservative therapy. This comprehensive approach begins with stringent rest from exacerbating activities.
So avoiding those repetitive movements we discussed.
Precisely. Any repetitive elbow flexion, forearm pronation, or forceful gripping should be meticulously avoided. Non-steroidal anti-inflammatory drugs, NSAIDs, are frequently prescribed to help reduce any associated inflammation and manage pain. Furthermore, broader lifestyle modifications are absolutely key. This isn't just about medication or exercises. Patients are generally encouraged to continue working, provided there are no prominent motor or sensory deficits compromising safety or function.
And physiotherapy.
Yes, physiotherapy and potentially chiropractic care are common and highly effective treatment options within this conservative framework. The duration of physiotherapy sessions can vary, but generally we see significant improvement with perhaps 4 to 6 weeks of regular appointments. The overarching goal is always to relieve pressure on the median nerve through various modalities. An elbow orthosis or brace can also be immensely helpful.
How does that help?
We often recommend it to provide a period of rest for the elbow, usually in a slightly flexed position, maybe 90 degrees, and keeping the forearm in a mid-rotation or neutral position. Wearing it continuously for at least 2 to 4 weeks initially can really help to offload the stressed structures.
Many of our listeners, being hands-on clinicians, will be keenly interested in the specifics of a home exercise program. Can you detail some of the neurodynamic and strengthening exercises that patients can perform to truly facilitate their recovery?
Certainly. The bedrock of therapeutic exercises for PTS involves nerve gliding techniques, often called nerve flossing or neural glides, alongside targeted stretching and strengthening. The critical insight for therapeutic exercise in PTS is this dual focus: neurodynamics enabling the nerve to glide freely within its fascial planes and myofascial release, specifically targeting the muscle tightness and trigger points that often contribute to or perpetuate the compression.
So helping the nerve move and releasing the pressure around it.
Exactly. These exercises are designed to help the nerves move smoothly and freely, reducing adhesions and improving vascularity. Based on neurodynamic treatment concepts, which aim to improve the mechanical properties and health of the nerve itself, effective median nerve sliders and tensioners include, well, there are a few key ones. First, the two-ended median nerve slider. This is fundamental. The patient begins by resting the palm of the affected hand flat against a wall, shoulder internally rotated, forearm pronated like a stop sign, but palm flat. From there, they slowly supinate the forearm while simultaneously side-bending the head and neck ipsilaterally towards the affected arm.
Okay, coordinating head and arm movement.
Yes, the coordination is key. It's designed to add tension distally along the nerve while creating slack proximally, allowing the nerve to slide without undue stretching. Reversing this motion, pronating the forearm while doing contralateral side bending of the head and neck away from the arm creates a proximal slider effect. This sequence is typically performed for 10-15 repetitions in 3 sets. And the absolute critical caveat: no pain should be felt. Smooth, pain-free movement within a comfortable range.
Very important point.
Absolutely. Then, for distal median nerve slider facilitation, the starting position is similar, but the head and neck are kept consistently ipsilaterally side bent throughout. The patient then only supinates the forearm to the precise point where no tension is felt, then returns to the start. The head and neck stay put, isolating the movement to the forearm for distal nerve glide. To improve proximal median nerve slider improvement, we start with the shoulder internally rotated, forearm mid-prone, creating initial distal slack. The exercise here is simply contralateral side bending of the head and neck, again, only to the point of no tension. 10-15 reps, focusing on proximal nerve movement.
So different variations target different parts of the nerve's path.
Precisely. There's also the one-handed tensioner, same start position, head neutral. The patient slowly supinates the forearm until a gentle tension is felt along the median nerve distribution. Hold for maybe 2 seconds, return smoothly. 10-15 reps, 2-3 sets, carefully monitoring for pain. And finally, the two-ended tensioner aims to enhance the nerve's viscoelasticity, its ability to stretch and return. From the start position, as the patient supinates at the forearm, they simultaneously contralaterally side bend the head and neck. This maximizes nerve elongation. Hold for 2 seconds, return 10-15 times. Again, paramount. None of these should cause pain. Any sharp or increasing pain means it's too aggressive and needs modification.
Excellent. Beyond the nerve glides.
Beyond nerve glides, other beneficial exercises directly address muscular and fascial tightness, which are crucial components of PTS. The Pronator Teres stretch itself. This can be done effectively a couple of ways. One method: extend the hand, elbow slightly bent, place a 5-10 kilogram circular weight like a small dumbbell or even a water bottle on the upturned palm, focusing weight on the thumb side. Hold for 30 seconds, repeat 5 times. Alternatively, stand with your back to a door frame, extend the affected arm behind you about 75 degrees angle, grasp the frame, thumb pointing down, then gently roll the biceps upward. Provides a deep pronator stretch, hold 10-30 seconds. For a general flexor stretch, targeting forearm flexor tightness. Extend the arm, elbow straight, palm outward like stop. Rotate the arm so fingers point downward. Use the opposite hand to gently pull fingers back towards the body. Hold 20-30 seconds. Nerve flossing or neural glides are essential for mobility. A common one: arm out, elbow bent 90 degrees, forearm up, make a fist, extend fingers up, thumb tucked in. Bend hand back like holding a tray.
Yeah.
Rotate hand and forearm forward, straighten arm, lowering like setting the tray down. Smoothly repeat 4 to 5 times, pain-free.
Visualizing that helps.
Yes. The standing palm press is a functional stretch. Stand arm's length from a wall, arm at 90 degrees, press palm flat against the wall, fingers up, hold for 5 deep breaths. Rotate arm so fingers point down, hold for another 5 breaths. Tilting the head away from the extended arm can increase the stretch. For supinator strength training, balancing forearm muscles, hold a hammer or similar weight, arm extended. Slowly drop the hammer head side to side, controlling the supination pronation. Repeat 15 times. Build strength in the opposing group. A standing curl and press with small dumbbells, say 1-2 kilograms. Start hands facing legs. Curl to shoulders. Rotate hands to face shoulders. Press weights overhead. Rotate hands inward. Lower back to shoulders, then sides. Full range motion, repeat 10 times. Strengthens the whole arm and shoulder complex.
Good variety there.
And don't forget myofascial release techniques, specifically for the Pronator Teres. Very beneficial. Elbow bent, palm up. Place opposite thumb near the elbow on the inside of the forearm. Rotate palm down to activate Pronator Teres. Find a tender spot. Apply firm but gentle pressure for 5 seconds. Crucial. Avoid triggering tingling or numbness, that's nerve irritation. While maintaining pressure, slowly rotate the forearm up and down 10 times. Then move the thumb to other tender spots along the muscle. Repeat.
Targeted release.
Exactly. And finally, for ongoing management, especially for those whose work involves repetitive movements, ergonomic adjustments are vital. Kinesiotaping can offer support. Anchor tape outside mid-forearm, stretch diagonally inwards, maybe 30% tension. Another strip from pinky side of wrist towards inside elbow, moderate tension, supports flexors. For computer users, ergonomic split keyboards, vertical mice, these can dramatically reduce that sustained forearm pronation, a key aggravator. Crucial for long-term management and preventing recurrence. The critical insight for therapists and you as clinicians is understanding why these specific movements and interventions work, addressing nerve mobility, muscle tightness, ergonomics, and how to select and progress them for each patient, not just handing out a list.
That's a remarkably comprehensive approach for conservative management, highlighting the depth of non-operative options available. However, what happens when these robust strategies, applied diligently over several months, don't yield the significant results we hope for? When do we shift our thinking and seriously consider surgical intervention for Pronator Teres syndrome?
That's the pivotal question, isn't it? Surgery is certainly not the first line, but it definitely has its place. We typically consider surgical intervention what a meticulous course of non-operative management, spanning that dedicated 3 to 6 month period, has demonstrably failed to provide satisfactory symptom relief. Crucially, surgical consideration becomes more pressing if there are objective findings, things like progressive muscle weakness, measurable motor atrophy, or abnormal electrodiagnostic results confirming significant nerve compression or ongoing pathology, despite conservative efforts.
So, objective evidence of nerve compromise pushes towards surgery.
Generally, yes. The main overarching goal of surgery, irrespective of the specific technique chosen, is to meticulously decompress the median nerve by releasing all potential compression sites. This is especially important because despite our best clinical and diagnostic efforts, the exact primary compression site can sometimes be difficult to definitively predict preoperatively. A thorough exploration is often needed.
Makes sense. What are the main surgical approaches?
There are typically 3 main surgical approaches, each with its own advantages, disadvantages, and specific indications. The first is the wide release approach. This involves a more extensive exploration of the median nerve throughout the proximal forearm. It includes a comprehensive release of all those commonly identified compression sites we discussed earlier: the ligament of Struthers, the Pronator Teres muscle, the lacertus fibrosus, and the FDS aponeurotic fascia, all in one open procedure.
The belt and braces approach.
You could say that. The primary advantage is a highest chance of achieving complete symptom relief, especially if the precise compression site is uncertain preoperatively. It also offers the surgeon an excellent clear view. However, the trade-offs include a potentially larger surgical scar, a slightly increased risk of compromising the nerve's delicate blood supply due to the extensive dissection, and perhaps a longer recovery period. Potential complications, though rare, can include incomplete release, recurrent symptoms, and, in severe cases, nerve ischemia.
Okay, what's the alternative?
The second is limited decompression. As the name suggests, this approach targets only 1 or 2 of the most likely compression sites based on preoperative clinical findings and maybe imaging. This is less invasive, typically resulting in quicker recovery times and smaller scars. More cosmetically acceptable, perhaps. The primary risk here, however, is a higher chance of missing other subtle but significant compression sites.
Which could mean needing more surgery later.
Potentially, yes. It could necessitate further surgery if symptoms persist or recur. So accurate preoperative localization is absolutely critical for this approach. It demands high precision. And finally, we have the endoscopic or mini-invasive release technique. This is the least invasive of the three, using specialized endoscopic instruments. Key benefits: minimal scar formation, potentially preserving the nerves surrounding blood supply more effectively, and leading to quicker post-operative recovery with minimal muscle function deficits.
Sounds ideal, but are there downsides?
There are. This technique demands highly specialized equipment and, critically, a highly qualified and experienced surgical team. The visual field through the endoscope is limited. It also carries a non-negligible risk of incomplete release, which might unfortunately necessitate a conversion to a wider open approach if the nerve remains entrapped during the procedure. Patient selection is paramount here.
Fascinating, Professor. Beyond these traditional surgical pathways, I understand there are truly novel interventional techniques emerging, particularly one involving ultrasound-guided perineural hydrodissection with 5% dextrose for PTS. This sounds incredibly precise and minimally invasive. Could you elaborate on this?
Yes, hydrodissection. What's truly fascinating here, in a developing area of interventional pain management, is the potential of this technique. Ultrasound-guided perineural hydrodissection using a 5% dextrose solution, D5W, is an exciting and emerging interventional therapeutic option. It's particularly promising in cases of peripheral neuropathy where nerve entrapment is present. While it has been extensively studied and shown promising results for carpal tunnel syndrome,
Yes, I've seen some data on that.
its application is now being actively explored and validated for other nerve entrapment syndromes, including Pronator Teres syndrome.
How exactly does it work?
The procedure itself involves using high-resolution ultrasound guidance, providing that real-time visualization of the nerve and surrounding structures. We use it to inject a precise volume of fluid, typically around 10 milliliters of 5% dextrose solution. The objective is to physically separate the median nerve from surrounding constricting structures, tight fascial bands, adhesions, even hypertrophied muscle. This is usually achieved using a fine 23-gauge, 2-inch needle, employing an in-plane approach, often distal to proximal, allowing careful hydrodissection along the nerve's course. In a recent case series, which provided some of the early evidence for BTS, patients underwent 3 injection sessions, spaced at 2-week intervals. So a protocolized approach seems likely. It's increasingly considered safe and effective for various nerve clamping conditions, including PTS.
That's incredibly precise, navigating such delicate structures with ultrasound. But beyond the mechanical separation, what's the deeper thinking? How does dextrose hydrodissection actually work, both mechanically and, perhaps more interestingly, pharmacologically?
This raises a profoundly important question, moving beyond just simple mechanics. The mechanism of action is indeed believed to be multifaceted. Mechanically, as you alluded to, the injected fluid physically separates the nerve from the entrapping tissues. Think of it as creating a buffer zone around the nerve. This decompression physically releases adhesions that may have formed between the nerve and surrounding connective tissue, thereby allowing nerve impulses to be delivered more freely.
Freeing up the nerve.
Exactly. And crucially, it also reduces the direct pressure on the nerve, which in turn improves its microcirculation and reduces the risk of local ischemia, lack of blood flow, which is a common contributor to nerve dysfunction. The technique aims to release the entrapment by effectively hydrodissecting the nerve from those constricting elements.
And the dextrose itself, does it do more than just provide volume?
Yes, pharmacologically, the role of dextrose is particularly intriguing. Dextrose is hypothesized to relieve pain through a sensorineural mechanism, specifically by downregulating the transient receptor, potential phenolate type 1 receptor, or TRPV1.
TRPV1, yes.
This receptor is often significantly upregulated on peripheral nerves in states of chronic neuropathic pain. It acts as a key mediator of pain signals. Dextrose is thought to reduce neurogenic inflammation by blocking this receptor. The receptor becomes abnormally active when connective tissue is injured, leading to a release of pro-inflammatory substances that activate the TRPV1 channel on C fibers. By blocking this, dextrose helps quieten those pain signals.
That's fascinating. Any other proposed mechanisms?
Furthermore, another compelling hypothesis suggests that glucose administration can actively reverse a state of local hypoglycemia around the nerve. In chronic neuropathic pain, the affected nerve and its immediate microenvironment can experience a localized glucopenia, or glucose deficit. This metabolic stress can lead to decreased ATP activity within the nerve cells and impaired function of the vital NAK pump, which maintains the nerve's resting potential.
So the nerve isn't functioning properly metabolically?
Correct. This in turn can cause progressive nerve depolarization and hyperexcitability, translating into increased noxious signal transduction, more pain signals being sent. The administration of dextrose, therefore, helps to restore the local glucose supply, normalizing metabolic activity, particularly of the C fibers, which respond quickly to glucose. By stabilizing neural activity and regulating neurogenic metabolism, dextrose thereby reduces pain and is even thought to actively promote nerve healing after decompression.
So it's a very sophisticated interplay of mechanics and biochemistry.
Indeed, it's not just pushing tissues apart.
That's a remarkably clear explanation of the underlying mechanisms. So with that understanding, what have the initial clinical outcomes been? From the studies using D5W hydrodissection specifically for Pronator Teres syndrome, are we seeing sustained results?
The initial case series, specifically investigating D5W hydrodissection for PTS, has, I must say, found very encouraging results. All patients in that particular series experienced what was described as satisfactory resolution of their symptoms, significant pain reduction, and a complete resolution of their tingling sensation.
And how quickly did they respond?
What's particularly compelling is the rapid response. At just 2 weeks post-first injection, patients reported, on average, a remarkable 50% decrease in their numeric rating scale, NRS, pain scores. And this improvement wasn't fleeting. It continued to progress. Both NRS and QuickDash, the quick disability of the arm, shoulder, and hand score dramatically decreased at 1 and 3 months post-treatment.
That's impressive. What about longer term?
And crucially, the long-term follow-up is very promising. At the 12-month mark, none of the patients in that series experienced any recurrence or relapse of their symptoms. Their NRS scores were consistently reported as 0 out of 10, and their QuickDash scores were also at 0%, indicating full functional recovery.
Wow, complete resolution at 1 year.
Yes, demonstrating excellent clinical and functional outcomes in the long term for these specific cases. For instance, one case involved a 50-year-old housewife presenting with severe pain, NRS 910, significant disability, QuickDash 45.5%. She achieved complete resolution by 12 months. Another, a 43-year-old woman, saw her NRS drop from 810 to a sustained 010, and her QuickDash from 31.8% to 0%.
But it's early days, presumably.
Absolutely. While this particular study, being a case series, suggested that 3 injections yielded considerable and consistent effects, it's vital to acknowledge its limitations. Larger, more robust, randomized controlled trials are still needed to further understand the optimal regimen, the best patient selection criteria, and the broader applicability of this exciting, minimally invasive approach. But it certainly offers a beacon of hope for certain presentations of PTS.
Professor, you've meticulously highlighted the diagnostic challenges in differentiating PTS from CTS. But what happens when a patient presents with both conditions simultaneously? This double crush syndrome phenomenon is something many of us in practice have encountered, where a seemingly straightforward CTS case just doesn't fully resolve. It truly forces us to broaden our diagnostic lens, doesn't it?
Indeed. The double crush phenomenon is a critical concept, and it truly is a clinical reality that we must be vigilant for. It refers to a situation where a nerve, in this case the median nerve, is compressed at 2 or more distinct locations along its course. While carpal tunnel syndrome is far more prevalent on its own, if a coexisting Pronator Teres syndrome is overlooked, then treating CTS alone will inevitably not fully relieve the patient's symptoms.
Leaving the patient still suffering.
Precisely. It leaves patients to endure further discomfort and often leads to additional, potentially unnecessary interventions, including revision surgeries. This is exactly why it's imperative to examine every patient presenting with typical CTS symptoms carefully for the potential presence of coexisting PTS and vice versa.
So how do we diagnose combined CTS and PTS? What are the clues?
Diagnosis can be challenging, but it is strongly suggested by a specific constellation of clinical signs. These include persistent paresthesia affecting the thenar eminence. As we discussed, that's a strong indicator of PTS involvement because the palmar cutaneous branch bypasses the carpal tunnel. You'd also observe pain in the proximal forearm, characteristic of PTS, and crucially, the presence of nocturnal paresthesia symptoms, which remains that hallmark of CTS.
So a mix of symptoms from both locations.
Exactly. Furthermore, a thorough physical examination would typically reveal positive findings for both conditions. So a positive Phelan sign and perhaps a positive Pronator Teres provocation test. along with a positive Tinel sign at both the carpal tunnel and over the pronator teres muscle in the proximal forearm.
Finding tunnels in both places.
Yes, that's a strong indicator, but a meticulous clinical examination is paramount. Before definitively diagnosing double crush, it's absolutely essential to exclude other potential sources of similar symptoms that could mimic median nerve pathology.
What sort of things?
More proximal compressions like thoracic outlet syndrome or systemic issues like peripheral polyneuropathies. We must also consider neurological issues originating higher up cervical radiculopathy from the neck, or even diffuse conditions from spinal injuries, head injuries, or cerebrovascular accidents. It's also important to specifically ask about any history of previous trauma or injuries to the affected limb, as scar tissue can create new compression points.
So a very thorough history and ruling out other causes.
Absolutely. While clinical diagnosis is key, in complex suspected double crush cases, objective confirmation with high-res ultrasound or detailed electrodiagnostics can be beneficial, especially before considering invasive treatment. However, it's a critical clinical pearl. Negative results from these ancillary tests should not definitively rule out double crush if the clinical picture and your examination findings strongly suggest it. Trust your clinical judgment.
That's a powerful reminder to remain vigilant and holistic in our assessments. If double crush syndrome is confidently suspected or confirmed, Professor, what does the evidence suggest for treatment? Is it sequential treatment or perhaps a simultaneous approach?
Current evidence, though still somewhat limited due to the lower prevalence of combined conditions, generally points towards an invasive simultaneous approach for established double crush syndrome.
Treating both at the same time.
Yes. Studies have indeed shown good outcomes with simultaneous arthroscopic release of the transverse carpal ligament for the CTF component and open decompression of the pronator teres for the PTS component. One retrospective study, following a cohort undergoing this combined approach, noted that a substantial 71% of patients experienced complete relief of both pain and paresthesia. The remaining 29% reported only occasional paresthesia and mild pain, but importantly, no persistent sensory deficit. So, good results overall.
That strongly supports addressing both sites.
It does. Furthermore, looking at patients who had initial CTS surgery but frustratingly continued to experience symptoms, a very challenging scenario. Subsequent pronator teres release in those patients demonstrated a significantly greater chance of full recovery of both numbness and pain, along with objective increases in grip strength.
So going back to release the pronator teres, help those with persistent symptoms after CTS surgery.
Yes, it compellingly underscores the importance of that comprehensive diagnostic approach up front. It highlights that if primary symptoms point towards PTS, but the patient also reports nocturnal paresthesia, coexisting CTS should absolutely be considered, and vice versa. The message is clear. If the clinical picture suggests dual compression, addressing both sites either concurrently or sequentially if one surgery fails to provide complete relief, offers the best chance for optimal patient outcomes. It truly emphasizes the complexity of the median nerve's journey and why we must look beyond the most obvious points of compression.
Professor, this deep dive has been incredibly illuminating. It's profoundly clear that while pronator teres syndrome might be less common than carpal tunnel syndrome, its accurate diagnosis and subsequent tailored treatment are absolutely vital for comprehensive patient recovery and satisfaction. The blend of specific, nuanced physical examination techniques, a granular understanding of anatomical variations, and the consideration of both established and advanced interventional options like dexterous hydrodissection truly offers a complete and modern picture of managing this condition.
Indeed. For our listeners, the key takeaway, I think, is that a meticulous, patient-centered clinical approach is indispensable. Recognizing the subtle but distinct clinical presentations, especially those differentiating features like nocturnal symptoms and the HAR eminence involvement, is critical for avoiding misdiagnosis and ensuring truly effective targeted management.
What stands out to me most from our conversation today is the imperative to consistently consider the possibility of both conditions coexisting, that double crush syndrome. It serves as such a powerful reminder that the median nerve's journey can be complex, multifaceted, and demands our vigilant attention beyond just the most obvious points of compression. It challenges us to think more deeply, doesn't it? To look for those less obvious culprits and ultimately to truly help our patients find lasting relief. Professor Moamam, thank you so much for sharing your profound expertise on this fascinating and clinically relevant topic. This conversation has provided invaluable, actionable insights for our medical audience.
My pleasure entirely. It's an important discussion to have.
And to you, our listeners, if you found this deep dive beneficial, please do take a moment to rate and share the show. It genuinely helps us bring more expert discussions your way. We hope this empowers you to approach median nerve compression syndromes with even greater precision and confidence in your daily practice. Keep learning, keep exploring.